Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name is Dr. Sayed Haider Jaffrey, Haematology SHO and aspiring haematologist.
And let's get started on today's topic.
From basics
to brilliance. Today we're going to learn about CMML. What do you know about CMML, Haider?
So I've heard of CMML, but I will be honest with you, I thought it was the same as CML. But what exactly is CMML and what does it affect?
Yeah, so that's I'm really glad you brought that up actually, because this is a really common problem that a lot of people that I've experienced this a lot with people, particularly when I'm on call. CMML, that extra M makes all the difference. It stands for chronic myelomonocytic leukemia instead of CML, which is chronic myeloid leukemia. And even though there's just that one extra M, it makes a big difference in terms of what the disease process is entirely. So CML is usually a disease more of middle-aged patients. And we will do a teaching session on CML. And it's a very exciting condition characterized by the BCR-ABL mutation, which you may or may not have heard of, the Philadelphia chromosome. Yeah, that's it. And has a really good prognosis, and overall survival and life expectancy is pretty much the same as that of age-matched controls these days on treatment. As CMML, chronic myelomonocytic leukemia, is actually really different in that it is more of a condition I like to think of as a cross between myelodysplasia and a myeloproliferative condition. So it's characterized by having a persistently high monocyte count, but we can't treat it particularly well, unlike that of CML. And it can limit your survival and is more a disease of older age. So it's an important distinction to make from the beginning that they are really different. And actually, if I think somebody has CMML on a blood film report that I'm writing, I will actually write it in full as chronic myelomonocytic leukemia rather than CMML, because our colleagues, particularly in primary care, will often think that they're the same thing. So go on.
When you say persistently high, how long would, for example, GP want to be looking out for it?
Yeah, so that's a good question. Generally in hematology, persistent means 3 months for something that's chronic. The diagnostic criteria we'll get into in a minute, but just to say about the incidence of CMML, it is the most common or most frequent myelodysplastic or myeloproliferative condition. So it's really quite common. It's out there. And also it's a disease of older age, as I said, with a sort of average age of 72. It has a median survival of 20 to 40 months. And one of the things that we worry about, as well as complications that you can get from CMML itself, is the transformation rate to AML, in which it can transform to acute myeloid leukemia in about 15 to 30% of patients.
That's not good.
Yeah. So if we get into the WHO definition then of how we actually say whether someone has CMML, we talk about essentially the diagnosis revolves around having excess monocytes. And these excess monocytes need to be persistent, so over 3 months in duration. They need to be absolute in terms of it being above or equal to 1. So a monocyte count of 1 or above counts as an absolute rise in your monocytes, but also it needs to be relative. So what I mean by that is the monocytes need to be raised relative to the rest of your white blood cell count. So they need to represent at least 10% of your total white cell count need to be monocytes. And then the other thing that you need to have, as well as the monocytosis, is you need to have either dysplasia, or genetic abnormalities. So genetic abnormalities, that can be picked up either through cytogenetic changes or molecular changes, which we will talk about when we talk about investigations in a minute. And that's kind of obvious because it's a malignant condition. But dysplasia, do you know what dysplasia is?
Dysplasia as in different cells, essentially they're not what they're supposed to be.
Yeah.
So their morphology is different on the
Yeah,
cell itself.
exactly. Yeah, it's a morphological sign, really. And it's basically that your cells that you're making just don't look right in some way. And there's a big range of different features of dysplasia. From on a bone marrow, you can get micro megakaryocytes, where the megakaryocytes that make platelets are really small. Or you can get things like nuclear to cytoplasmic synchrony, where the maturation of a red blood cell's nucleus to cytoplasm is not kind of happening at the right timeline. And so features of dysplasia can be picked up either on a blood film or a bone marrow, but still rely on our visual human eye being able to pick up dysplasia. So that's the diagnosis. So it's basically you need a monocyte count of greater than or equal to 1, which is greater than or equal to 10% of the total white cell count. And the other thing you need is either dysplasia or a genetic abnormality. Now, in 2022, the WHO actually lowered that threshold to 0.5. So greater than or equal to 0.5 as the monocyte count cutoff. However, if you're making a diagnosis of CMML with a monocyte count of only just above 0.05 or 0.05 and above, then you must have both dysplasia and a genetic abnormality. Okay. And then the other thing to say is that with CMML, there's no one easy diagnostic test like there is in, for example, CML, where if you have the BCR-ABL, that's a really useful pointer to what the diagnosis is. It's not as easy with CMML, and therefore it's really important that we've excluded other conditions. So we need to have excluded CML, myelofibrosis, pre-fibrotic myelofibrosis, polycythemia rubra vera, and essential thrombocytosis, i.e. the other myeloproliferative conditions. We also need to make sure that there's no PDFGR and B mutation, no FGFR1, and no JAK2 rearrangement. And also we need to make sure that there's less than 20% blasts in the bone marrow. And obviously that's because if it gets to 20% blasts and above, then that condition is then AML, which often, as we said, CMML can transform into. So once you've got your 3 diagnostic criteria and you've done your exclusions, then you can make a diagnosis of CMML.
Okay. Well, how would you divide CMML? Is there classification for it?
Yeah, that's a good question. The most useful way that I like to think about CMML is kind of talking back to what I said at the beginning, where I see CMML as a bit of a crossover condition between MDS and a myeloproliferative condition. So what I mean by this is you can divide CMML into what we call a myelodysplastic CMML, where you have a white cell count of less than 13, and then a myeloproliferative CMML where you have a white cell count of 13 and above. And I don't know why 13 has been used as the cutoff, but it has. But the reason why it's useful is because the myelodysplastic CMML tends to sort of plague patients with problems with low counts, so anemia and thrombocytopenia and that kind of thing. As the proliferative CMML tends to cause problems because of the high white cell count. Because these white cells, they're monocytes. Do you know anything about monocytes in terms of what they look like down the microscope, for example?
They're quite large.
Yeah.
Larger than the other leukocytes, from what I remember from just my minute knowledge from med school of morphology. And they're the scavenger cells, so they'll help with macrophages to kind of engulf microbial particles.
Yeah, perfect. Yeah, exactly. And so I think the point you make about them being large cells is really important. I mean, when we see a high monocyte count on an automated differential from a full blood count done by a lab machine, we will often question whether those monocytes are actually blasts instead of monocytes, because both blasts and monocytes are large, but also the monocytes themselves, by being large, they're quite sticky. And if you get a high white cell count with monocytes, they can start to cause problems of leukostasis, where the blood flows too slowly, particularly in the brain and in the lung. And that can happen at lower white cell counts than you might expect. So the myeloproliferative CMML, patients can get issues directly related to having a high white cell count. It also probably is genetically distinguished from the more myelodysplastic type, in that the proliferative CMML tends to occur with activating RAS pathway mutations, and generally tends to have more adverse clinical outcomes than the myelodysplastic CMML, and they get more in the way of splenomegaly and extramedullary disease, because, as you say, monocytes float around in the blood, but their role in normal health is to then go out into the tissues where they become macrophages, and they then do phagocytosis of bacteria and things like that. And as a result, they have a tendency, when they're malignant monocytes, to want to go out into the tissues and want to infiltrate things, and that can be really problematic. So that's how I think about them. So you've got your myelodysplastic and you've got your myeloproliferative CMML.
Okay. And would there be any other presentations with regards to, because most blood disorders, especially in the forms of leukemias, would have other symptoms besides the leukostasis? Would you perchance see organomegaly or night sweats in those subsets of patients that you think have CMML?
Yeah, absolutely. So you can get constitutional symptoms. So you can get weight loss, you can get fatigue, that can be a big one. Drenching sweats, as you say. You can also get low counts and symptoms secondary to that. So if you're anemic, shortness of breath, chest pain, and low platelets, which can lead to bleeding. Splenomegaly, as you said. And you can also get effusions around the heart, so pericardial effusion or pleural effusions, from the sort of inflammation and tissue infiltration by the monocytes. You can also get skin deposits, which sometimes you need to do a skin punch biopsy to confirm as part of the condition. And also there is this associated link with autoimmune disorders, which is actually not unique to CMML, but all myeloproliferative conditions are associated with autoimmune disease. And we think that's to do with the immune system not working very well in autoimmune conditions, and that allowing clonal escape, whereby your immune system is not as good at surveying for a malignant clone that might develop in the bone marrow. So yeah, those are the other ways in which it can present. But often it's worth saying, a lot of the time CMML is picked up coincidentally on serial full blood counts and a blood film that comes through the lab.
Okay, so say I have a patient that's come in with raised monocytes of 2, and it's been going on for about 4 months. What investigations from a hematology point of view would I do next?
Yeah, so I mean, you're going to want to do a full blood count, and you're going to want to then look at that full blood count and how that's trended over the last at least 3 months to get an idea of it. Because one of your big differentials is going to be what if you have somebody with raised monocytes?
Infection?
Yeah, infection, inflammation, anything reactive, basically. So you want to look at a trend and see how long has this been going on for. You're also going to want to get a blood film in which you're looking for features of dysplasia on the blood film. And then one other investigation that can be really useful is immunophenotyping, or what we abbreviate to flow, of the peripheral blood. Do you know how flow works? Are you familiar with that?
Not entirely.
Okay.
Does it run through, is it through the cytometer? And that's about as much as I know of flow, to be honest. So how does it work?
Yeah, so flow basically is a really useful tool to allow us to see what is expressed on the surface of white blood cells. And we do this by using specific antibodies against antigen on the surface of white blood cells. For example, an anti-CD14 antibody and an anti-CD16 antibody. And they're labeled with different labels, those antibodies. And we add a couple of different antibodies to our mixture of white blood cells, and then we wash the white blood cells. So any antibody that hasn't bound is washed away. Then we pass each of those white blood cells one by one through a small aperture, and a laser is shone at the white cells. And that laser then bounces off, creating forward and side scatter. And the amount of forward and side scatter is dependent on the antibodies that have bound to that white cell. And we can therefore interpret, based on the pattern of forward and side scatter, with these quite complicated looking graphs, we can work out what the expression pattern is on the white blood cells. And you can order different panels. So you can order an acute panel, which typically contains antibodies against markers of blasts, looking for various different markers of acute leukemia. You can also order a chronic panel, which is more looking, using a cocktail of antibodies against markers seen in more chronic conditions like chronic myeloid leukemia, chronic myelomonocytic leukemia, lymphomas. And then also a myeloma panel is the third one. And obviously that's antibodies against markers seen in plasma cells. Okay. So you can use a chronic panel to look at the peripheral blood flow to see what the expression is of CD14 and CD16. And that's really helpful, particularly if you're a bit stuck as to whether the patient's monocyte count is reactive or malignant. Because, for example, you might have somebody with rheumatoid arthritis and you notice they've had a chronic persistent monocytosis for quite some time. And you don't know if it's just reactive to the fact they've got this autoimmune condition, or whether it represents CMML, of which you know they're at higher risk of because they've got an autoimmune condition. And so a classical monocyte will have CD14 positive and CD16 negative. As a reactive monocyte will be CD14 weak positive and CD16 positive. So the opposite. And we call classical monocytes MO1 and reactive monocytes MO3. And basically, if you have greater than or equal to 94% monocytes are MO1 on flow, then that is quite specific and sensitive to distinguish and to tell you that those are probably malignant rather than reactive. So that can be really useful.
It was really, really amazing how far we've come with just the advancements.
Yeah,
in terms
definitely.
of having to diagnose these things. Now, you said earlier that you can divide CMML into two kinds, which is the proliferative and the dysplastic. Is there any other way of classifying it?
Yeah, I mean, one of the other really important ways to classify it, which is based more on prognosis, is into CMML1 and CMML2. And this is based on the blast count in the bone marrow. So the bone marrow would be your final investigation that you do need to do for patients that you're considering treatment for CMML. So a bone marrow wouldn't always be appropriate. If you've got a really old, frail patient and their counts aren't too bad, white cells aren't too high, HB and platelets aren't too low, you might not bother doing a bone marrow because it's quite an invasive investigation. But let's say you've got a younger patient in their 40s or 50s and they've got this persistent monocytosis, you're definitely going to want to do a bone marrow. The bone marrow is useful because you firstly look at the aspirate under the microscope to see for features of dysplasia and to look for an excess of monocytes. But then you're also going to want to send the bone marrow for flow, this time probably an acute panel, to quantify the amount of blasts to make sure that it's less than 20% and that you're not dealing actually with an AML. And then you also want to send both cytogenetics, which is often where you have to put the bone marrow aspirate into a culture medium. They grow the cells and then they shock them when they're in the metaphase stage of proliferation. And you then look at the chromosomes under the microscope, and you usually will examine 20 mitoses and look for various translocations because this can be prognostic. And then you also do molecular tests, which is more PCR-based testing, usually in an EDTA sample. And there are 4 genes in particular that we know are prognostic in CMML. And I remember it as the acronym NARS, which is not particularly catchy or useful, but it's NRAS, ASXL1, RUNX1, and SETBP1. And those are 4 genes that are not good if you've got the presence of those mutated.
Okay.
And so
I'll try to keep that in mind.
Yeah. So the classification of CMML1 and CMML2 is based on the blast count. Okay. So I remember it in terms of the bone marrow blast count because the numbers are easier in my head. So CMML1 is less than 10% blast in the bone marrow, so 1 and 10%. As CMML2 is less than 20% blast in the bone marrow, or the presence of our rods. So do you know what our rods are?
The name rings many bells, but I can't say for certain.
So they're basically myeloid granules that kind of clump together to make rods, and we see them in myeloid blasts. And the presence of them basically kind of trumps the percentage of blast that you have, in that you could count only 5% blasts, but if in some of those blasts you've got our rods, then that makes it CMML2 rather than CMML1. And we see a similar thing when we classify MDS. So it's really important that we do a little our rod hunt at the end of our reporting of a bone marrow morphology to make sure that we haven't missed that.
Okay, so it's under 20 for CML2, and then over 20 would be pointing you towards AML.
That's right, exactly.
Right.
It's over 20%, then it's all the presence of our rods, then it's actually AML instead.
Okay.
There used to be a CMML 0, but that was removed by the WHO because it didn't really provide any prognostic significance. So now we just deal with CMML 1 and 2. And it's a useful way to classify CMML because it's part of a lot of the different prognostic scores.
Okay. So how else can you prognosticate CMML?
Yeah, so I remember hearing a really good talk at one of the Myeloproliferative conferences a couple of years ago, where somebody said there were many prognostic tools for CMML, but no clear winner. And it's true, there are lots and lots of different prognostic scores, but no one unifying score that everyone tends to use for CMML, which is quite unusual because in a lot of other conditions, there's a sort of standard scoring system that everyone uses. One that people tend to use is something called CPSS-MOL, which stands for CMML Specific Prognostic Scoring System. And it basically uses a combination of cytogenetics, so good and bad risk cytogenetics, the 4 high-risk molecular mutations, so the NARS acronym, and then also some clinical features, which include blast count, hence the CMML 1 and 2, white blood cell count, transfusion dependence as well. But all of them are much the same, and they basically use to predict overall survival and risk of progression to AML, basically. In terms of cytogenetics, poor cytogenetics are having trisomy 8, chromosome 7 abnormalities, or what we call complex cytogenetics. Do you know what complex cytogenetics is?
I've just seen it written in notes. So I'm not entirely sure, but what do you mean by complex cytogenetics?
Yeah, and it's worth just saying what that actually is because it's banded around a lot in hematology as a term. Complex cytogenetics is where you've got 3 or more cytogenetic abnormalities. So once you've accumulated, a Scrabble hand of 3 mutations, 3 different chromosomal abnormalities, then no matter what your chromosomal abnormalities are, you're probably not going to do very well because you've got complex cytogenetics. Good cytogenetics. Oh, sorry. What were you going to say?
Does that just indicate that it's a much poorer prognostic marker for them? Okay.
Yeah. And good cytogenetics are isolated loss of chromosome Y. So that's one of the other things used in the scoring systems. But yeah, it doesn't really matter what scoring system you use as long as you know how to interpret it, I guess.
And because earlier on you said it is somewhere between MDS and MPN, and there are so many ways of prognosticating CMML, does that mean that it's relatively less picked up on? Because you're not essentially looking for CMML, and you said you have to exclude so many things as well on top of the diagnostic criteria that it takes a bit longer.
There probably are a lot of patients out there with undiagnosed CMML, but I guess if it's not causing them any issues and considering it is a disease of older age, that's not necessarily something that I think would justify a screening program, for example, like a national screening program.
Okay.
Yeah.
In terms of treatment now for CMML, how would you approach it?
So I think the first thing always with any malignant condition in hematology is to think, is this patient a transplant eligible patient or not? Okay. So if they're fit enough for a transplant based on their comorbidities and their performance status, then you need to think, okay, they're fit enough for a transplant, but does their disease justify needing a transplant? And in low risk CMML, you don't necessarily need to do much about it. If they've got not much of a white cell count and their HB and platelets are okay, then they have a low risk of transformation to AML, then there's not much that you necessarily need to do. But in high risk CMML, so when you do your CPSS mole, for example, and it comes up as high risk and the patient is transplant eligible, then actually you probably do need to do something. And the reason why you have to weigh up whether it's high risk, low risk, and whether they're fit enough is because there is such a morbidity and mortality associated with doing an allogenic stem cell transplant that you have to be able to justify those risks. So if you're a high risk patient and you're fit enough for a transplant, you need to be identifying them right at the beginning so you can refer them to a transplant centre for further discussion of this. In terms of the outcome from transplant for young patients that are fit and have high risk disease, unfortunately, it's not great. Overall survival is about 30%, which is probably worse than that of MDS. But if it's the only thing that will offer you even a chance of a cure, and we know that they're at high risk of progressing to AML if they're a high risk disease. So that would be your options. And in terms of what induction you would use to get those patients to transplant, CMML1 patients, you'd probably take them directly to an allograft because their blast percentage is less than 10%. But if they're CMML2, then you probably want to go in with an AML style induction. So something like DAR chemotherapy and get the tumor burden down, get the blast percentage down before then going to an allograft. And there's no real role for intensive chemo without then subsequently consolidating that with an allograft, because the even if they achieve a CR, it's not durable without a transplant. So that's why you do need to go on and do that. So that's for patients that are young and fit with bad risk disease. Obviously, most patients are going to be not transplant fit that have CMML.
Right. And given that you're saying the median age is about 72.
Yeah.
And we know that a lot of people within that age bracket have comorbidities and would therefore be transplant ineligible. What would the treatment options for them be?
Yeah, exactly. And that's a really relevant question. So I'm glad you asked that. I think the first thing to say is that watch and wait approach is actually pretty appropriate for most older patients with CMML. There are no demonstrated thresholds for which we should be starting treatment or thinking about treatment for CMML. But generally, I would say a hemoglobin of less than 100 or platelets of less than 30 or a bleeding history or bleeding complications would make you think about, is there anything we can do to try and improve this patient's full blood count? In terms of treatments, the two treatments really are hydroxycarbamide and azacitidine. So hydroxycarbamide you can use in CMML1 with a raised white cell count. So the more sort of myeloproliferative CMML, but without a high blast percentage, so less than 20% blast, or actually less than 10% blast, isn't it? Yeah. And how the hydroxycarbamide works is it just puts a generic brake on all proliferation within the marrow. So it doesn't actually have any disease modifying effect, and there's certainly still clonal evolution going on underneath the hydroxycarbamide. But what it can do is help control a rapidly rising white blood cell count, particularly to prevent these older patients from suffering symptoms such as splenomegaly and tissue infiltration from the white cells and things like leukostasis type symptoms. And it can also help with the catabolic symptoms. So people can lose quite a lot of weight and be quite fatigued with having to produce so many white blood cells. So it can be helpful for that as well. But be aware that it can worsen cytopenias, particularly in patients who have an elevated but stable white blood cell count. Those patients can in particular get quite a bad anemia and thrombocytopenia from the hydroxycarbamide. And then it becomes a balance of what's actually impairing the patient's quality of life more.
Mm-hmm.
So that's
And
hydroxycarbamide. Sorry, what were you going to say?
With the hydroxycarbamide, would you give them platelet and transfusion support along with that? And how long exactly can you be giving hydroxycarbamide for?
Yeah, that's a good question. You can give the hydroxycarbamide for as long as it provides benefit in these patients. So that's a really individualized decision.
Mm-hmm.
And you wouldn't really be giving platelet support unless they have bleeding problems, because it's not seen as an intensive chemotherapy or an intensive treatment, and you're kind of expecting them to have low platelets ongoing, and therefore you can't just keep pouring platelets into these patients if they're not getting bleeding side effects. In terms of your red blood cell transfusion, this is a chronic disease, and therefore this would fall under the remit of deciding whether the patient would have symptomatic benefit from a blood transfusion. So there was quite a big paper in the BSH which showed that transfusion thresholds, which are individualized in terms of when to transfuse and individualized triggers based on symptoms, really improved quality of life of these sorts of patients with chronic conditions. So it would be working out whether a patient gets a benefit from a bag of blood, and if they do, what sort of threshold for them do they start getting a benefit?
Yeah, I think that's really worthwhile to remember, because as juniors, we see a hemoglobin of below 70 and we start freaking out, or even 80 for just the thresholds that we know. And a lot of the times patients aren't symptomatic and they have that for quite some time. And I think you taught us earlier on that it's always riskier to give blood than to not give blood. So you have to always balance the risk and benefit. And it's really good to remember what you've just said about individual thresholds.
I think for these patients with chronic conditions where you're aiming to improve their quality of life, being more liberal rather than restrictive in how much you transfuse them is a good thing and will improve their quality of life. But in patients that are having intensive chemotherapy for like AML, for example, and they're young and they can tolerate low hemoglobin, then you should be using the restrictive transfusion threshold of 70. Yeah, absolutely.
Okay, and what about the other group of patients?
So the ones that are eligible for azacitidine treatment, so those are patients with CMML2. So that's where they've got less than 20% blast, but they're high risk of becoming AML. But specifically with a white cell count of less than 13, so the sort of non-proliferative high risk CMMLs, I guess, as well as also the CMML1 patients with significant cytopenias. These two groups of patients, so CMML2 with a white cell count of less than 13 or CMML1 with significant cytopenias, are both eligible for this hypomethylating agent called azacitidine. Now, azacitidine is a subcutaneous injection. It's quite annoying because you have to make it up on the day. So often these patients have to come into a day unit to have an injection each day. And original trials were using 7 consecutive days of treatment out of every 4-week cycle. But obviously in the NHS, that can be quite difficult. So we adopt what we call a 5+2 approach. So Monday to Friday injections, then have the weekend, and then Monday, Tuesday, or Thursday, Friday, and then Monday to Friday the following week out of every 4 weeks. But it's quite a well-tolerated chemotherapy. And it basically, the idea of it is that it probably slows disease progression to AML and therefore gives patients a longer overall survival. And in the case of CMML1 with significant cytopenias, it can help with the cytopenias by, I guess, reducing the monocytes and the blasts in the bone marrow.
Does it have any specific side effects? I'm sure all chemos have their own specific things, but this particularly.
Azacitidine, generally, I tell patients that they should expect to tolerate it quite well. but you can get specific injection site reactions, which can be quite painful under the skin. And it can cause quite a lot of GI upset. In particular, constipation can be a bit of an issue. And it can drop your counts like hydroxycarbamide can. And sometimes that means we will maybe sort of go a bit off license and drop 2 of the days and do a 5-day regime, for example. Because really, you're not trying to cure these patients or anything or get them into remission. You're just trying to improve their quality of life. So it's a bit of trial and error for each patient to see what works for them and what doesn't.
Right. Yeah, that makes sense. Yeah.
Yeah. So I guess those are the only 2 treatments: hydroxycarbamide and azacitidine in CMML. Other things to think about, though, are if the patient's particularly having issues with anemia, then approach it from a myelodysplastic point of view. So what's their EPO level? Is it low? If it's low and they've not had much in the way of transfusions so far, then using the Nordic score, which is a scoring system we use in myelodysplasia, in which it predicts that people will respond to EPO therapy if they've got a low EPO level and if they've not had much in the way of blood transfusions yet. Then you can think about trialing an EPO injection, so something like RNS, 300 micrograms every 2 weeks for 8 weeks, and see if that boosts their hemoglobin a bit. And then you can up that to 500 micrograms every 2 weeks if needed. And then transfusion support, which we've already talked about, and having those individualized thresholds. The other thing is, if you've got a patient with CMML and they particularly have a bad thrombocytopenia and they're getting bleeding from it, thinking about maybe trialing steroids if it's just a thrombocytopenia, in case there's an autoimmune element of sort of ITP, in which sometimes giving some steroids can help boost the platelet count. And then thinking about other supportive care measures, so things like tranexamic acid, 1 gram 3 times a day for nosebleeds and that kind of thing. And obviously platelet transfusions if you really need them. But remember that that's going to be an ongoing thing and therefore has its risks and also its impact on a patient's quality of life having to come to a day unit on a regular basis.
Okay. And I'm just throwing that out there that towards the end of that, in terms of it, even platelet transfusions, would you consider TPO agonists? Or would you leave that?
Agonists, that's a good question. They've got a bit of a checkered past in terms of using TPO agonists outside of ITP really. And that's because they were shown in MDS trials, early MDS trials using TPO agonists, particularly high-risk MDS patients. TPO agonists actually were shown to increase the rate of progression of MDS to AML.
Oh, okay.
Yeah, which probably nowadays, if you just gave TPO agonists to the low-risk patients, like low-risk MDS, for example, or low-risk CMML, it probably would be fine, but people are quite anxious about that. So I certainly wouldn't be trying a TPO agonist in a CMML patient, at least without discussing it with my colleagues and maybe taking it to a sort of a more regional MDT.
Okay. Well, that was overall very, very informative. What would the take-home messages be?
Yeah, so I think that's a good place to summarize, isn't it? I think take-home messages are: 1, CMML is not CML. And it's often coincidentally picked up, and it is extremely common. It's the most common myeloproliferative neoplasm. And it can be thought of in terms of both proliferation and dysplasia, a kind of cross between a myelodysplastic and a myeloproliferative condition. And you can divide CMML into above and below a white cell count of 13 for a more myelodysplastic phenotype versus a myeloproliferative phenotype. And it's really important when you're diagnosing CMML to exclude all the differentials, so infection, inflammation, autoimmune conditions, other malignancies like solid cancers are really important to exclude. And the second thing I would say is note that the WHO have recently changed the cutoff for diagnosing CMML. So you do need a monocytosis, but instead of it being greater than or equal to 1, you can now diagnose it on the basis of it being greater than or equal to 0.5. But remember, it needs to be greater than or equal to 10% of your total white cell count, and it needs to be persistent over 3 months. And you need to have dysplasia and or mutations. And if you're using the threshold of 0.5, then you need both dysplasia and mutations. And I would say that the two real treatments to think about in CMML, once you've established whether your patient is transplant eligible or not, is hydroxycarbamide and azacitidine, which feels slightly unsatisfactory that we're limited to just those two things. And that's because there's a real paucity of evidence in CMML. It's not been until recently that it was actually recognised as a separate condition to that of myelodysplasia. And so a lot of trials have had CMML lumped together with MDS, making it really difficult to know how we should be treating CMML. But watch this space. I think there's more interest in CMML these days, and with the reclassification, I think it's going to lead to more diagnosis of CMML. And certainly it came up in my part 1 exam. I had to write an essay on CMML.
Oh, right.
So it does come up. It is important, and it is the most common myeloproliferative neoplasm. And as we get an aging population, it's going to become more and more relevant.
Well, thank you very much, Anhard.
No worries.
I feel like I've, from the start to finish, actually figured out what CMML is, and that it's not the same as CML.
Yeah.
So I'll keep
good.
passing that along to other people as well, and hopefully they'll listen to this podcast and be able to differentiate. Because even when I was trying to research this myself, there's not that much in way of podcasts or lectures that aren't 3 hours long to try and explain exactly what it is. So hopefully this does help quite a lot of people.
Yeah, great. Thanks so much, Ada. I'll see you next time.
Thank you.
Bye.
Bye.
Thanks again for listening to Basics to Brilliance Haematology podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.